So I'm not an oncologist by training, but I will say the only targeted therapy right now that is sort of FDA approved for colorectal cancer. Well, besides the classic KRAS, NRAS, and EGFR treatments that have been done for years with 5-FU and leucovorin, Xeloda, all of those usual and customary treatments, is the option of immune checkpoint blockade therapy for colorectal cancers that have high microsatellite instability. Unfortunately, for other tumors, we found that patients who have germline mutations in homologous repair deficiency genes like BRCA1 or BRCA2 or other genes in that pathway, they benefit from treatment with a targeted therapy known as a PARP inhibitor. Doesn't seem to be working as well in colorectal cancer patients who have BRCA1 or 2 mutations. It's possible that their cancers aren't caused by their BRCA1 or 2 mutation. It's not known to be an elevated colorectal cancer risk for people with hereditary breast ovarian cancer. So PARP inhibitors are not as effective in treatment of those cancers, even if the patient does have a BRCA1 or 2 mutation. So right now, I think, the person I was debating with who debated the con said, yeah, this isn't really going to change treatment right now for colorectal cancer patients, the germline finding, because we'll know if the tumor is microsatellite unstable anyway to choose the immune checkpoint blockade therapy. So at this point, I would say germline genetic testing isn't adding a lot in terms of treatment for colorectal cancer beyond what you can get from testing the tumor itself for MSI high, for KRAS, NRAS, and EGFR mutations. But I think in the future, we'll see that improve. And that may be the last piece of information we need to convince people that all colorectal cancer patients need testing. I think finding out the germline information for them and their family members is sufficient. But certainly the added benefit of a therapy change would help.